This is a young 40-year-old patient who presented to us with a lamellar cataract and was planned for a clear corneal phacoemulsification with intraocular lens implantation. The side port entries are made. Now, continuous curvilinear capsular rhexis is initiated. A flap is raised, and this flap is maneuvered in a circular fashion utilizing both shearing and dripping forces to get a uniform 5.5 mm rhexis. Here, we plan the rhexis using the dimensions of the lamellar cataract as a template. Now, using a 2.8 mm kerato, a biplanar clear corneal incision is created. Balanced salt solution is injected underneath the anterior lens capsule, and you can see the fluid wave crossing the center of the nucleus. It is then repeated on the opposite pole as well. The nucleus is gently tapped at the center to decompress the capsular bag. You can appreciate a beautiful golden ring, and the nucleus is gently rotated to free the remaining corticocapsular adhesions. Trenching is now initiated in the phaco 1 mode, and since this is a relatively soft cataract, the red reflex is apparent almost immediately. And burying both the instruments at the bottom of the trench, cracking is then done and both the poles are split. Rotating the nucleus 180 degrees, the opposite poles are also split. Now, quadrant-wise emulsification of the nuclear fragments is done. In such soft cataracts, it is advisable to use low power and high vacuum settings to prevent undue damage to the corneal endothelium. You can see that a very good followability of the fragments are achieved, and there is a stable anterior chamber throughout. Now, bimanual irrigation and aspiration of the cortical matter is done. Since this is a young patient, the cortical matter is usually very sticky, and therefore care should be taken while stripping it off and aspirating it. Now, by switching instruments with both hands, the subincisional cortex is also removed. Now, a gentle hydrojet is done to polish off any cortical fibers which may be adherent to the posterior capsule. This helps in greatly reducing the incidence of posterior capsular opacification in these young patients. Now, under irrigation, the foldable intraocular lens is gently injected into the capsular bag. The lens is gently rotated, and the trailing haptic is also tucked underneath the anterior lens capsule. Finally, the main incision and the side ports are then hydrated.